So guys, if you haven't seen any of my other videos, I am tapping into South Asian Heritage Month, and we've spoken to my dad about his journey from Africa. I've spoken to my sister, who's a psychiatrist, about mental health within the South Asian community, which is on IGTV. And today I have the lovely Harsha. She's a GP trainee and very interested in gynecology. She is actually one of my brides that's booked in with me, and whenever we've met up, this is what we've spoken about. So I thought it'd be a great opportunity to get her on and answer your questions and just talk about all things women's health, because I think within the community it's something that we don't talk about that much. I'm gonna get Harsha to come on with me. There we go. Hi.
Hi, hello.
I'm good. How are you?
I'm good, thank you.
Busy at work?
Yeah, it was all right. It's been okay. I'm off now until we change on Wednesday, so I'm good.
That's good. That's good. I remember like speaking to you when the pandemic started, and actually just a little bit before that, how busy you were, and then the first few months. So it's good to hear it's getting a little bit quieter and maybe the pressure's coming off a bit.
It is coming off a bit, but I suppose we just all have to be sensible and not go crazy. So should stay like that.
Exactly, stay in, guys. That's it. So, Harsha, can you tell us a little bit about yourself, why you chose, well, you haven't exactly chose gynecology yet, have you? But you're a GP trainee, and why you're so interested in women's health.
So I'm Harsha. I'm from Birmingham. I've grown up around here. I went to school here, and then I went to London to study, and then I came back to work. I'm currently a final year, well, in 2 days I'll be a final year GP trainee, so I've only got a year left. And I've taken a special interest in women's health, and I've had that since med school really, but more so in the last couple of years. And it's something that I think we should be talking about a lot more, so I'm really glad you're doing this.
Yeah, and I'm glad you were able to join me, because it's nice to be able to bring someone on that you kind of already know a little bit, and we've had that conversation before. We're just going to be talking to a lot more people about it now, which is great. So why do you think as a community we don't talk about it that much? Or do you actually find that, or is it just a misconception that I have that we don't talk about it within the South Asian community?
So I don't think that's a misconception. It's been my personal experience. I'm not sure about everyone else. So I think I grew up in what I would call a pretty standard Gujarati household. It wasn't too strict, but not too lenient. And it's not a topic that I openly discuss with my mom or my family. I actually asked my mom earlier on today, and she said, "Oh, I had no idea about these things. When I started my period, I thought I was dying. I didn't know what it was." And then, so we were like, why does this happen? So it's quite a personal, it's an embarrassing topic. But I think one of the things that we possibly thought of was that there are certain cultural traditions which associate our health and normal bodily functions with a lot of shame, stigma, and guilt. Like, for example, if we're on our period, there's certain things that we can't do, or there's certain parts of our body that we shouldn't be talking about until we get married, because supposedly, culturally, you're supposed to wait until we talk about sex or anything along those lines until we're married. So I think young women grow up with this, and they reinforce it by doing the same thing to the next generation.
That is so relatable. I think, like, you touched on periods being a taboo subject, and it's one of my favorite taboo subjects to talk about, because within our family we started off very similar to you, where we didn't so we're both Gujarati. We go to celebrate Navratri or Diwali at the temple, and initially my mom was like, oh, if you're bleeding, you can't attend, and you have to stay at home, and then once you're like clear, then you can go. And it never really made sense. And then my grandmother spoke to her and said, if we're not bringing up our girls to be strong, independent women who can practice spirituality at any time, then what's the point? So that's where our kind of thought process changed. But then I come across so many women through my job, and we talk about it, and every family does it so differently. And even though we like to think we're in a different country from India and we're so forward thinking, actually we still have very backward practices. So I think people say that if you're on your period, you're like unclean, shouldn't touch things. I know some families will practice you shouldn't go in the kitchen, or you shouldn't pray. Obviously medically there's no research that kind of states that, right?
There's nothing unclean about it. It's your body doing what your body should be doing, and
Mm,
that's how we were made. It shouldn't be
yeah.
something of shame at all.
So we'll go on to periods a little bit later.
Mhm.
We had one really interesting question about, so the person wrote that, you know, if you're struggling to consummate your marriage because of your husband's values that he's been brought up with, how can you kind of talk about it or combat that issue? Because that's something, like, sex is important in a relationship. It's not just
Mm.
about supporting each other, but that plays a big part too, right?
Yeah, no, completely. I think surprisingly, this is more common than you think it is. I've seen it quite a few times, usually in newly married couples, where I think they've both come from backgrounds where it's such a taboo thing. It's something that they haven't even spoken about. They haven't done at school. They don't even know how to have that conversation with each other. And I think we say this a lot and it can be quite overlooked, but the basis is just being able to talk about it. It's being able to talk about how you feel about your body, how your partner feels about your body, and the sorts of things that you're comfortable with. And it's then maintaining and building that trust in that relationship. Um, there's no quick fix to it. There's not something you can just say, yes, we can do it now. It's something that you build up over time. And I think sometimes because we have that conception, it only happens after marriage, we suddenly expect it to be amazing, like the day you get married. It's not going to happen like that. I mean, you don't know your partner that way. You need to get to know them.
Yeah.
And it's something that you will build up over time. And it's natural
Mm.
to have that worry, I think, completely. But just talking, being open, and sharing your concerns and that vulnerability will really help.
That's really sound advice. And I think, like what you said, just communicating with your partner about what it is
Mm.
or what you're nervous about actually just makes it a little bit easier, I suppose, for both people, because generally we would both be in the same boat, right?
Yeah.
So going back to periods, so I think we're going to talk more about the medical kind of description of periods and why we have them, and why it's important that we have them. So I know I've had like questions when I go and see my GP or a nurse, and they'll be like, oh, do you have a normal period? And I'm like, I think it's normal, but I don't know how to compare it because I don't know what anyone else's normal is, right? So can you talk us through what a normal period is?
So there is no such thing as a normal period. A period essentially is day one of your menstrual cycle. And the period is the shedding, is you losing the lining of your womb. And that tends to present as blood. Now, typically it looks like we're losing gallons and gallons, but it's only about 85 mils. So I think that's what, about
Wow.
15, 16 tablespoons. It's not actually that much.
Yeah.
Um, and your menstrual cycle is day one of your period and the number of days between that day and day one of your next period. And now for women, it's normal that this can range from anywhere from 21 to 40 days. There is not a
Right.
normal number. It's completely dependent on you, on your body. It typically lasts about 3 to 8 days. Again, that can
Mhm.
vary with depending on what you normally have. And um, it's regulated by four hormones. It's LH and FSH, which come from your brain, and estrogen and progestogen, which come from your ovaries. Now,
Mm.
periods are different for everyone. We can't really say they're normal, but what's normal for you is normal for you. So I suppose if someone's
Mm.
asking you, are your periods normal? I suppose what we're looking for is, are you bleeding as often as you normally bleed? Is it as heavy or as light as it usually is? Is there any
Mm.
more pain, or is it less painful than usual? So those are the sorts of things I think that we mean when we ask, is your period normal?
So it's good to compare back to yourself and like maybe have like somewhere where
Mm.
you note it down or have an app where you can log it.
Yeah.
It's it Since I've been using a menstrual cup, that's really helped me understand how much blood comes out every month, and then I'll realize that, oh, maybe I was a little bit heavier this month or not so much, but it's a good way to be able to see. So we had a question about fibroids. What are they? How can they affect your period? Is there any way that you can control it or stop it from happening?
So fibroids, without getting too technical, are growths, but they're not cancerous, they're not harmful, usually in the lining of the uterus, which is the womb, or the muscle layer of the uterus. Now, these can range from about grape size to some women, you can even be tennis ball size. You can have one,
wow.
or yeah, you can have one, or you can have quite a few. Now, the most common symptom that this gives is heavy, painful periods compared to your normal period. So you can be going along completely fine, and then suddenly, usually late 20s, early 30s, you'll be like, oh gosh, what's happened to my period? It becomes very heavy, it becomes very painful. You might notice that your abdomen's a bit more bloated. There's nothing you can do to stop them, I'm afraid. There is some evidence to show that it can run in families. So if your mom or your sister's got them, you might be more likely to have them. Now, they're what we call estrogen dependent. So the more estrogen you have in your body, the more they grow. So that's why during, if you become pregnant or if you're on the pill, that can stop the growth, but it's not really going to shrink them completely, and they can't go away completely. You'll always have them.
Okay, but if you see like an irregularity, then definitely just go and see your GP.
Yeah, definitely. If at any point you think this isn't normal for me, something's different, I think the best line of advice is always see your doctor.
And how many months should you track it? Like, say if I had very painful periods, should I kind of wait to see how next month is and then maybe span it over 3 months and then go and see a GP? Or would you say, first month you should just go?
The general rule of thumb is if you notice changes in your period and you're premenopausal, so that means your periods haven't stopped, general rule of thumb is usually about 3 months. If something's happening past 3 months, see a doctor. If you're postmenopausal and you're getting a period, you need to go to a doctor straight away. It could indicate a problem.
Okay, so we were talking about like hormonal changes, and we had a question about irregular periods and how to manage that, and how to kind of manage acne on the skin as well. Any advice on that? I know we've got quite a long bit on contraception, so we can come on to that later, but anything else that you could recommend, or we can come back to it?
So irregular periods, most commonly in South Asian women, are associated with hormone imbalances. The most common hormone imbalance in South Asian women is polycystic ovarian syndrome, PCOS or PCOS, however, whatever you want to call it. Now, I think I should make clear there's a difference between polycystic ovaries and polycystic ovarian syndrome. Polycystic ovaries are where the ovaries contain a number of small, little fluid-filled pockets with an underdeveloped egg in, usually about 12, not really symptomatic at all. And that's polycystic ovaries. And a lot of women have that without even knowing that they have that. Then you've got polycystic ovarian syndrome, which is a collection of symptoms. Now, that's diagnosed if you meet at least 2 out of 3 criteria. And the criteria being irregular periods, excess androgen. So by androgen, I mean male hormones like testosterone in the body. That's usually measured by a blood test, and that gives you symptoms such as acne, facial hair, male pattern, hair loss and hair growth, as well as oily skin. And the third one is polycystic ovaries, which is usually diagnosed by an ultrasound scan. So it's 2 out of those 3 before you get diagnosis. Symptoms, I think we've already touched on it. It can differ from woman to woman, but I think some of the most common ones include weight gain, facial hair growth, oily skin, which are the ones I think women are most bothered by. And of course, that does have mental health effects as well, because I suppose, like you've touched on before in some of your other posts, I think we feel a pressure to look a certain way. You've got your hormones going crazy, and your skin's not looking great, or your eyebrows are out of shape, you're suddenly growing a lot of hair. It's not very nice. In terms of management, there's not a cure for polycystic ovarian syndrome, but it's more about symptom management. So some of the common things that we focus on. So for example, you touched on hair growth. So there are things that you can do yourself, such as removal, waxing, shaving, tweezing. Laser hair removal is also an option, but these options aren't funded by the NHS at all. There is a topical cream, I can't ever pronounce it properly. It's eflornithine, and that's a cream that you can use on freshly washed skin. You can ask your GP for it, usually once to twice a day, and that limits facial hair growth. It's usually effective after consistent use for about 4 to 6 weeks. Then
Okay. Sorry.
no, go on.
Button in. Carry on. No, you carry on.
And then I think the other thing you touched on was acne. Again, you've got options. You can't get rid of the acne. It'd be topical options such as creams or long courses of antibiotics or dermatology referral for something stronger. But I think one of the most common and frequent options that many people use to manage their polycystic ovarian syndrome is the pill. And that's because the pill not only regulates your periods, you know what's happening, it also helps with a lot of the other symptoms such as the hair growth and oily skin.
So we're going to come on to contraception in a second. I just want to check because we've got a question. Guys, if you have any questions, then pop them in the comments section, just because I have no idea how to use like the questions box. Okay, so we had one question. How to help ease period pain? Doesn't everyone wants to know the trick.
So that's a question we get quite commonly. Period pain typically that we tend to see starts earlier on in life. So as soon as you've started your period, pains tend to typically become worse from about 15, 16 years of age. And the best thing that you can do, because of the certain receptors that you have in your womb, is ibuprofen. Now, ibuprofen can help with the pain. So what we advise is that you start taking it a day before your period and then at least 5 days into your period regularly. It's important you take it with food, and that can help with period pain. Now, the other option is there's a stronger version of ibuprofen called Methanomic Acid. Now, that you can only get from your GP. You take it the same way that you take ibuprofen, don't take them together. And this not only is really effective for period pain, but it can also lighten the flow of your period as well. If those options are something that you wouldn't want to look into, you can also look into contraceptive options, which many women use, which we can touch on later.
Okay. It's weird because I feel like, I don't know if it's just memory or my pain thresholds got better, but when I started my period, I felt like it was really, really unbearable and really painful. And as I've got older, maybe I'm managing it better or keeping myself busy. But I found that it doesn't hurt as much as I remember it doing so when I was younger. Is that a thing, or is that just all in my mind?
Yeah, that is a thing. So no, it's not in your head. It is a thing. So typically, girls tend to start their period around at the age 11 or 12, and it's quite normal for the first 5 to 6 years for them to be irregular, heavy, and quite painful. After that, they tend to regulate themselves, and the pain should ease.
Okay. And anything, I know loads of women get bloated like in the run-up or during period time as well. Is there anything that we can be doing to kind of, you know, just look after ourselves and not feel bloated and still want to, you know, eat things that we enjoy and not just binge on chocolate, if that makes us feel good?
Unfortunately, it's all hormone related, so there's not that much you can do. But I think self-care measures, again, are really important. They're really underestimated. If you feel like taking it easy, take it easy. But exercise, surprisingly, will help. Even just going for a walk, getting out, getting some fresh air. There's a lot of evidence to show that sort of thing can help your mood and bloating right before your period. Eating well, so dark chocolate is very good, but try not to binge as much as you want to. It's not going to make you feel any better. Dark chocolate and green tea, those I found women, it tends to help them most.
Yeah, so a couple of things that we can do at home. That sounds really good. So we're going to move on to contraception. We had quite a few questions on contraception. So we're going to break it right down, just in case people don't know and want to pick up some new information. So what is it for, and what does it do?
So contraception essentially stops you getting pregnant, but that's not the only use that contraception has. Other uses include some women want to control their periods, like it fits better around your life if you've got a busy job, busy lifestyle. If your periods are heavy or irregular, it can help control them. Or it can help in terms of a lot of women suffer from premenstrual syndrome. It can help with that as well. So it's not just about stopping you getting pregnant. There are other uses for it as well. Now, I'm going to try and summarize it into 4 broad categories. So types of contraception, there's natural family planning. So that's where you track your own body. So you track things like your body temperature, the discharge that you're getting, your mood, your weight, and you try and predict when you're ovulating. It's not a method I tend to recommend because, well, I don't think the success rates are that great for it, because you don't know how your body's going to react to things like stress or heat or whatever's going on in your life. The next method, second method of contraception is barrier. So barrier contraception includes condoms, diaphragms, and caps. Now you can get all of this free from your local umbrella or local sexual health clinic. And the added benefit to barrier contraception is that it prevents against STIs, which are sexually transmitted infections. Your third and biggest group of contraceptive methods are hormonal. So hormonal, now that includes the pill. You've got your two types of pill, which are your combined contraceptive, which is the two hormones that I spoke about earlier, estrogen and progestogen, or you've got the progesterone only one. And I'll touch a bit on that, about which you can use and which you shouldn't be using later. You've got the patch, which is the two hormones. You've got the vaginal ring, which again is two hormones. You've got the implant, which is a small tube that goes into your upper non-dominant arm and lasts for 3 years. You've got the injection, which tends to go into your upper thigh, which lasts 12 weeks. And then you've got the coil, which can last anywhere between 5 to 10 years, depending on the type it is. And then finally, your fourth method of contraception is sterilization. So that's for females, is where you get your tubes clipped, and for men is where they get vasectomy. But out of these, like I said, hormonal tends to be the most popular because it has a lot of other benefits as well. But barrier contraception is the only type that will protect you against STIs.
How do we approach the topic of contraception? Like, maybe if you want to talk to your partner about it, should we be talking to a partner about it, or is it completely 100% all right to just go and get contraception if we feel like we're not ready for a child? Or, you know, because there's so much pressure, right? For, you know, you get married and it's like, right, I have a child now, but you might not want to. So
when's your child
anything
coming?
that you see, or...
It's personal choice. It's completely your choice. It's your body. It's your hormones. You're putting it into your body. It's going to affect you. I often think I try and encourage women to speak about it with their partners, just because contraception can have different effects. It has many positive effects, but you will have days where you feel a bit off, or you might feel a bit bloated. So it's nice for your partner to know. And I think it is better for your partner to know, because this is, if you're doing it to not have a baby, surely it's something that the both of you should know about. You should both understand how it works, and try and encourage your partner to be involved and get them involved in that conversation about how it works and the effect it has on you.
Do you find that there's a certain type of contraception that South Asian girls or women opt for? Because I find like when I went to the doctor, I was kind of like, oh, I want the pill, and I didn't really know about anything else, and I wasn't really ready to listen about anything else. That's all I wanted, and that's what I wanted to walk out with on my prescription.
From what I've seen, a lot of younger South Asian women tend to, that is right, they tend to request a pill because of the effects it can have on skin and hair growth. Because especially with darker hair, darker skin, you've got much coarser hair. And if you've got something that only helps you with your periods or helps you with not having a baby, of course you would go for the pill. Now, there are two types of pills. There's the combined contraceptive one, which is the one that's most commonly used. So that's estrogen and progestogen. And out of these, depending on what you're using the pill for, there are two that I see commonly used in Asian women, and that's Dianet and Yasmin. And the reason for that is they have effects on the male hormones in your body to help reduce the male pattern hair growth and to help clear up your skin. But what commonly tends to happen is if you don't ask for a particular type of pill, you'll be started on if you're suitable for the combined pill, that is, you'll be started on the basic microgynon pill. But you can ask for Yasmin if you want to. The other type of pill is the mini pill. So there might be certain reasons why you can't take the combined pill. So if you've got a history of migraine, if you've got a history of blood clots or heart disease, you'll be advised to take the mini pill, which is just one hormone. And that tends to do a similar thing really, but just only affects the one hormone.
Alternatives to pill, you've kind of touched on, you know, what types of contraception there are. Do you think there's anything that you would recommend rather than the pill?
I think, yes, we try and encourage what we call long-acting reproductive, long-acting contraception, the LARCs. So those are the implant, injections, and the coil. In young women, we try not to encourage the injection too much, because there is some evidence to show that it could have an effect on your bones if you're growing up. So what I commonly would advise, if you're using it for a long time, the implant, which is the small tube in your arm, or the other option you've got are the coil. Now, there are two types of coil. You've got the hormone coil, which is often known as the Mirena coil, that eventually will stop your periods completely. And it's a common option for women who've had their children, who don't want to have a period anymore, and they just need something to get them through until the menopause. But you've also got the copper-based coil, and this isn't something I see as often because it can cause heavier, more frequent bleeding, but it is an option if you don't want a hormone-based coil. In terms of alternatives to the pill, you have got alternatives, but they are longer-acting alternatives.
Whereas with the pill, you can stop it the next month, isn't it? So
yeah,
it's a bit more controllable. Any effect, like mood effects, that you might have if you do take a pill?
So it's a bit of this is a bit of a difficult one because it's individual for the person who's taking it. Some people take the combined pill or the mini pill because they notice that their mood prior to their periods is so bad, and it can actually have a beneficial effect. Whereas some women notice, and it is quite a common thing, especially for the combined pill, that they do notice that their levels of anxiety and low mood can go up a bit. Usually this is controllable just by a few what we call lifestyle measures. So getting out a bit more, encouraging yourself, talking to other people. But if it becomes too much, it's something that you should see your doctor about, and you could try and consider other methods of contraception.
Would you say do your research before you go to the GP about the types of contraception, and what should you be like saying to the GP, or what should you be asking for when you get there?
Definitely do your research. Otherwise, if you know a bit about the type of contraceptive you want, it makes it a bit easier for the doctor sitting in front of you to try and tailor what you want. Otherwise, you might have to sit through quite a long conversation about which is fine again, about all the different types. But if you're a bit more informed on what you think will suit your body, it's always better to be informed. The sorts of things really that you should be asking your GP is, or you should be telling your GP, they should be asking you this as well, but is your own personal medical history, because that will depend on the type of pill or type of kind of contraceptive that you have. You should be asking your GP or telling your GP why you want to use it. Is it because you want to regulate your periods? Is it because you don't want to have a baby? Because then you can look at different options which might be best for that specific mood or for that reason. Or is it because you want to control your skin or your hair growth? Again, then you can look at different types of options. So my advice is, if you're going in to see your GP for contraception, know what you want and tell them the reason that you want it, because then we can look at different sorts of methods that will suit you best.
That makes sense. One of the questions that we had was how to be aware of things that don't feel right in the body.
So you know your body best. Anything that feels out of the ordinary for your body, you should be flagging up. But one of the things that I try and encourage with every woman, is to self-examine. So every time you have a shower or every time you're getting changed, examine your breasts. Are they normal for you? Is there something that you feel is a bit off? If you've got any concerns, see a doctor. Again, like I said, it's about knowing your body. So if you notice something that's different for you, your periods are different, your bleeding pattern's different, the pain pattern's different, see a doctor. It's also really important to keep up with screening programs as well. So for women, there are 2 screening programs that you really should be aware of and make an effort to keep up to date with. So you've got the breast cancer screening, which is a mammogram that starts for women age 50 and carries on until they're 71, and it's every 3 years. Now, depending on your family history, you might be called sooner, but typically it starts age 50. But don't wait till age 50. If you think there's something wrong, go in. And the other one is the cervical screening program. Now, I'm sure a lot of you follow Janisha, but recently she put out a survey, which, thank you, which was me looking at the rates of cervical screening in South Asian women. Now, cervical cancer isn't as prominent in South Asian women, but it does happen. And a smear test it's an internal test, and it's a small sample of your cervix, which happens from the age of 24 and a half to the age of 64 every 3 to 5 years. Now, the rates of screening in South Asian women is lower compared to the general population. And some of the reasons are the reasons that we touched on before, such as feeling uncomfortable with the stigma associated with anything to do with sex or smears or internal body parts. So keeping up to date with your cervical screening program is something else that I would recommend, and how to be aware of your body.
Let's do some questions. We've got 2 in, and then we'll go back to talking about smear tests, because that's how our conversation started back then. So we've got a question. Are your chances to get pregnant lower at age 43?
So yes, they are a bit lower. They're not completely lower, but they are lower than prior to the age of 35. It's a bit unfortunate, actually. So in obs and gynae, if you're over the age of 37, unfortunately, they class you as an older mother, because after that, you're more likely to have complications from pregnancy, but you're also more likely to find it difficult to conceive. If you are finding that's the case, don't wait around until you do conceive. See your doctor, because there are services to help you to try and conceive.
And then we had a question, how many weeks or months does it take for iron stores to replenish from supplements? Heavy periods / fibroids causes ferritin levels to drop to 11 to 14, and what is an ideal level to combat fatigue?
So iron stores typically take 2 to 3 months to restore back to their normal levels, and that's if you're taking your supplements properly. So that's 2 to 3 times a day, every day for 2 to 3 months. There isn't an ideal level to combat fatigue. Again, it's all personal. So for someone might have, I don't know, a ferritin level of, or a hemoglobin level of about 10, which they're fine with. But another person might find that they're fatigued. The other thing I think to look out is not just supplements, but it's dietary. So if you're vegetarian and you don't eat meat, it's about keeping up with your dark green leafy vegetables. These are great sources of iron.
Okay, so guys, we're going to wrap up in a bit. We're going to talk about smear tests for a bit, but if you've got any questions for Dr. Harsha, then just pop them in the comments and then I'll pass them on to her. So smear tests, I've always gone for mine because I think it's so good to know about what's going on in your body, and you know, if there is something that needs to be checked, then at least you can get the process going. And we're so lucky that the NHS offers all this stuff to us for free, so why not make use of it, right? But I have some women who say that I haven't been because I have not had sex yet. Would that be the case if you're a 30-year-old virgin? Should you not go?
You have to go. It doesn't matter if you've had sex or not, go for your smear test. So to give you guys a bit of background, cervical cancer is all changes in cervical cells. So the cervix is the opening, it's the neck to the womb, which is at the top of the vagina. The changes are most commonly caused by the HPV virus, which is the human papilloma. I can't ever say it properly, so I always like HPV virus types 16 and 18. Now, without again getting too technical, there are 4 types that are most commonly known. So there's 6 and 11, which are associated with warts, and there's 16 and 18. Now, the cervical cancer vaccine, which has been introduced for young girls, I think when I was at school, it was introduced when I was at school, but now for young boys as well, protects against all 4 strains. That doesn't mean you shouldn't go for your smear test. Now, what happens at a smear test is it tends to be a female clinician, it's a female doctor or a female nurse, and you lie down on the couch. It's usually about 5 minutes or so. Not going to lie, it's not the most comfortable examination, but it's something that you can usually bear. There's a small to medium-sized speculum that's popped inside of you, and that's opened, and then the neck of the room is visualized. From that, we scrape a small brush along the opening to the cervix, and we take a sample, and then that's sent off, and that happens every 3 to 5 years. Now, what that sample looks for is the virus that causes these changes. Now, that virus typically is more common in women who are sexually active, but it can occur if you're not sexually active. So that's why it's really important to go for your smear test, because there's a lot of evidence to show the earlier you catch it, the earlier you catch these changes, the more successful, you might even prevent further complications.
Just another question. I know my experience of it, but would you say that it hurts?
I didn't find it that pleasant. I don't find them that pleasant. It can hurt. It can hurt. I'm not going to say go in there and expect no pain. If you've had children and they've been delivered vaginally, it's probably not going to hurt. You've had a child pass through there. But if you haven't, or if you haven't had sex, it's not the most comfortable experience, but it's not going to hurt. If you can insert a tampon, you can usually go through a smear test.
Okay, so we're going to do some questions now. So we've got one that's come in that says, could you give some information on how to seek help for difficulty getting pregnant? My experience is generally lots of advice given regarding rituals and taking certain concoctions of herbs, but this can delay a woman seeking help with conceiving. Can you give a brief description on how to help and the process of fertility treatment? P.S. for all the aunties watching, I'm not asking this advice for myself.
So typically what happens with fertility treatment, your first port of call is your GP. And your GP will ask you, how long have you been conceiving? So there are certain risk factors that we would look for. For example, are you aged over 35? Have you had previous pelvic surgery? Have you got polycystic ovaries? If you meet one of these risk factors or checkboxes, and you've been trying to conceive, so what I mean by trying to conceive is you've been having regular sex 2 to 3 times a week for the last 6 months, then you'd be eligible for a fertility referral. It's also quite important to clarify a lot of some of the stories that I've come across, that people need to know what sex is and what happens. So also make sure you're doing it properly.
Okay.
I've heard stories where it's the wrong orifice or they just didn't know what it was. So yeah. Anyway, if you don't meet these risk factors or checkboxes, usually what your GP would advise is you should have at least been trying for a year before you go to fertility services. Now, what happens at fertility services is you'll go to a fertility clinic. Now, that either tends to be a GP with special interest, or it will be an obstetric registrar or consultant. And what they will do is a couple of things. So they'll take a history. It will be both you and your partner. You're both expected to be there. And what they will do is they will take a history from you both. They'll go through things like your medical history, your drug history, etc. Just they'll get to know you. The second thing that they will do is that they will examine you. So they will do a pelvic examination. So what I mean by that is that they'll examine your uterus. They will take swabs because on the swabs we can pick up things like infections which might be contributing to why you aren't conceiving, but also it will help for later investigations. And what I mean by that is, one of the reasons, if you haven't got any pre-existing medical conditions, is that some women can struggle to conceive because they've got problems with their tubes. So what happens then is, you, again, this is quite technical, you have a dye inserted inside of you and it's spread up through your uterus and into your tubes. So you'll probably undergo investigations like that. Now, if all of these investigations come back with a reason, they'll treat the reason. For example, if one of the tubes is blocked, they'll sort that out. Or if it's because you're not ovulating, they'll sort that out. If there is no physical reason that you can find, and neither you or your partner have a child, then you would likely be eligible for a round of IVF.
Amazing. Let's see, we have some more questions. Also, we need to talk about menopause before we leave as well. So the next question is, have you got a special medical information page? I've learned so much watching this live, especially the screening, than I have ever been taught at school by a GP.
No, I have a lot of trouble with Instagram, as you probably know. I don't know what a lot of it does, but I can try. I can try.
Yeah, you should. I think, you know, there's lots of space for information like this to be passed around, because I find Instagram is full of great information, but also information that's not always correct. So, you know, you could post stuff about that. Okay, also a brief summary on HRT, if we can.
So I think, yeah, before we speak about HRT, probably touch on the menopause, because that's what it's used for.
Okay.
So the menopause typically happens for women aged 45 and over. It's classed as early menopause if it's before the age of 40. There's no blood test to diagnose the menopause. Well, there is, but that's only if you're quite young. But over the age of 45, we would say you're going through the menopause if your periods start becoming irregular, you notice some mood changes, and you notice hormonal changes. So that tends to be skin changes. So it's a bit like PMS, but a bit longer, really. And that's when we'd say you're going through the menopause. We say your perimenopausal is the year before your last ever period, and the year following your last ever period. So that would be perimenopausal. Following that, you are menopausal. Now, when you're menopausal or even perimenopausal, your hormones are all over the place. You will feel like it's the day before your period, probably 24/7, which no one really likes. And the option that we can then use is something called HRT, which is hormone replacement therapy. Now, there are two types of hormone replacement therapy, and they both depend on whether you have a uterus or not. The first type is estrogen and progestogen. So those are the two hormones that we mentioned earlier. And you can get that via a pill, or you can get that via a patch. And the reason there are two hormones, you are replacing the estrogen. The lack of that is causing the symptoms that you're experiencing, the hot flashes, the mood changes. The reason we give you progestogen is if you have a uterus and you give someone estrogen without giving them progestogen as well, you are increasing their risk of cancer of the uterus. If you don't have a uterus, then we can just give you estrogen. So typically you can start HRT from when you become perimenopausal, and depending on the type you want, if you still want periods, you can have something called cyclical HRT. It's where you take breaks in your HRT, so you have a fake period. Or you can have continuous HRT, so your periods will just stop. Typically, we say no more than 5 years, or not past the age of 55, because there are some associations with breast problems, but it's quite safe overall.
Anything else that you want to add about everything else that we spoke about? Because we've got probably about 10 minutes, and I've just thought of something that we haven't touched on that much. But guys, if you've got any questions, then please let us know. But is there anything, Harsha, that you'd like to add so far?
No, I think it's been quite comprehensive. We've gone through quite a lot, and I think
Definitely.
we've managed to touch on the important things that I thought we should get across.
Definitely. Okay, we've just had another question. So, as a physiotherapist, I've come across many Asian women with the condition of oh, I don't know how to say that, vaginismus
Vaginismus, yeah,
in women's health physiotherapy, especially in women post-marriage who have never been sexually active before.
yeah.
Do you
It's
think there
quite.
is a link?
I think there is a link. Vaginismus, there's a few causes behind it. What it means is that the entrance or the opening to the vagina is tight. So anything that you try to pop in there, or every time you try to have sex, your body clenches up, it tenses, and nothing can physically go inside. Um, Now, the first, I think, like you were saying, the predominant reason behind it is psychological. It's not your body, it's not your muscles. So I don't want you to think that there's something wrong with your body or muscles. It's purely that they're tensing up every time something comes near them.
Mm.
Now, there are a few options for this. It's mainly psychological. So I know there are specialist sexual therapists. I haven't come across them personally. I haven't worked with them, but I know they do some really good work to try and explore that with you, to try and explore it with both you and your partner. But I think other options include dilators. So it's where after you've had some sort of psychological support, you can start using, by dilators, I usually mean like a small tube. You can use a small tube to pop inside of you, and you gradually get bigger and bigger and bigger until you get used to that sensation and your body relaxes around it.
Mm. And do you think, let me just get it, do you think there's a link between Asian values and beliefs in women developing this condition?
Completely. The majority of women I've seen with vaginismus tend to be Asian women, and the reason for that is, I think, like we said earlier, sex is such a taboo subject. It can often be considered quite shameful, and if you're
Mm.
getting involved in it, if you're trying to talk about it, I think when you feel that guilt, when you feel, is this the right thing? Of course, your body's going to tense up. Of course, your body's not going to want it. So I do absolutely think that there is a link between these things.
Let's quickly touch on pelvic floor dysfunction, prolapse, and problems following C-section or vaginal birth.
So yeah, pelvic floor prolapse is more common with a vaginal birth rather than a C-section. So by a C-section, I think the majority of you know what that is. It's where a cut is made into your lower abdominal muscles and your uterus, and the baby's taken out. With a normal vaginal birth, baby just comes out the bottom. And this is more associated with cervical, uterine, and vaginal prolapse. You've got a couple of options, but usually the most common option for what midwives and GPs advise post-birth is your pelvic floor Kegel exercises. They,
Mm.
and to describe, I think we should all be doing them regardless of whether you've had a baby or not, 3 times a day if you can remember, maybe if you're just sat at your desk. Imagine you're having a wee and then try and stop that wee. And that is a Kegel, that's a pelvic floor exercise. And try and do that for about 8 times, 3 times a day. So management options for pelvic floor dysfunction, most common option is the ring pessary. So that's a big ring and it's popped up inside of you and it hoists everything up. There are surgical options, but I think we try not to explore those, and especially what with everything going on at the moment, it's not happening at the moment
Mm.
at all.
So last thing I wanted to ask, well, not ask, but just something that came to my mind was about breastfeeding. And you know, we quite kind of go upstairs and breastfeed. I've also had some people say that it's shameful to breastfeed and you should try and just use formula, and then there's shame around formula and you should breastfeed. But from what I've heard and what I'm aware about is that it's not possible for all women. Sometimes it doesn't work, sometimes it works. It can be quite painful. So any advice about that, or any cases that you feel that, you know, can help shed a bit of light?
So breastfeeding, of course, is always encouraged. But I think often because it's so encouraged, it's seen as best for baby, there's often that guilt and pressure that new moms face that they should be doing it. There's no preference really. If you can breastfeed, breastfeed, but there occasionally you will have problems with breastfeeding. So the baby might not latch on. You might find it painful, or maybe you're not expressing enough milk. If that does occur, then of course use formula milk. There's no shame to it. There's nothing wrong with you, and you shouldn't be made to feel as though you're a bad mother just because you're using formula milk. I think the point that you mentioned about hiding breastfeeding is a really good point. I've actually been out, I think I was in town somewhere at some point, and someone was breastfeeding. I didn't have a problem with it. And then some other guy walks past and says, oh, you should cover yourself up. This is wrong. Like, this is what your breasts were designed for. Why not use them for what they've been designed for? Why do you have to go and hide that away? I mean, I just think no one should feel shamed for breastfeeding and using their breasts for the reason that they're there.
I saw a post today about wearing masks and how we feel suffocated and feel extremely hot. And they said, imagine how the little baby feels while the baby's breastfeeding and the mom's having to put a blanket on top of the baby's head so that the boob can't be seen, right? So I think maybe we definitely need to talk about it more and be a bit more comfortable, but also respect the mother's decision whether she does want to breastfeed in the open or if she doesn't. It's got to be her choice at the end of the day, right?
Of course, yeah, it's the mom's choice, whatever's best for mom. A happy mom is a happy baby. It's a cliche, but it always works.
Amazing. So I think that brings us to the end. Can you tell us, like, where, if anyone has any questions, where they could possibly find a bit more information or where they should be looking, rather than, because I know Instagram has too much information and it's not always correct.
Best places for information is the NHS website. Other places include patient info. If you just type in patient info into Google, there's a lot of information, which is quite simple to understand, and it's got pictures. Otherwise, you're always welcome just to drop me a message and I can try and help you out.
Amazing. I think you're going to have to get that Instagram page started off, Harsha, and I'd be happy to help you. We've just had a message from... I'll help you any day. So just had a message from Dhokia that says, great talk, Harsha. Hope everyone can take away the medical advice and feel empowered to see their GP when they need to. It's time we celebrate our sexuality, sexual organs, as was done by our culture many centuries ago within the ancient Indian culture, which is so true, because we're finding, you know, all sorts of scriptures and stuff.
Yeah, completely. Yeah, I agree.
Amazing. Thank you so much, Harsha, for taking time out, because I know how busy you are and how busy you are at work. So hopefully this video will save, and I'm going to pop it on IGTV. And guys, if you could share it, because we need to make this topic about women's health, you know, normal rather than a taboo topic. Got some nice messages coming in for you, Harsha. So thanks for coming on. And if there's anything else you want to see, let us know. I am hoping to get another GP doctor on to talk about men's health, because just how it is important for us to talk about our bodies, it's also important to know what goes on with the other sex as well, so that we can generally help each other out and have the conversations, right? So yeah, keep an eye out. I've got a few more talks coming, but thank you so much, Harsha, and we'll touch base about your wedding and stuff soon. Lots of love to you.
Thank you for having me. Bye.
Bye. Bye.